Pediatrics. She has worked in government maternity hospital in Pondicherry and Karaikal. She started a basic newborn unit. She is a pioneer of starting the basic newborn unit in government maternity hospital, which has grown beyond imagination now. So during a period of service, she has served more than 1 lakh babies, but unfortunately she took voluntary retirement and now joined new medical center. She's now also the roaring pediatrician despite her age, okay? And she was also the joint secretary and past president of IEP Kadlur chapter, and also now the secretary of Puduvai Pedicon. We warmly welcome ma'am. We're very happy to have you today as a chairperson for the next session. I now invite the speaker, Dr. P. Selvakumar, to give the talk on re-emerging infections, pertussis, and diphtheria. Dr. P. Selvakumar is a professor of pediatrics of Tanjore Medical College. Madam is also, sir is also Senate member of Tamil Nadu Dr. MGR Medical University, past president of IAP Tanjore chapter 2021. He is also an executive board member of IAP Tamil Nadu chapter for the last 5 years. Over to you, sir.
Respected chairperson, other delegates, very good evening to one and all. Firstly, I would like to thank the organizers for having extended an invitation to me and making me the last speaker of today's deliberation. My sincere pranams to all the delegates who have stayed put here till the fag end of today's scientific deliberation. In the next 15 minutes, I would be enlightening you regarding the incidence, reasons for re-emergence, clinical presentation, management of diphtheria and pertussis. Diphtheria, after the introduction of immunization, the incidence of diphtheria drastically reduced. Over the last few years, like maybe 5 years, there is an increasing trend in diphtheria cases which have been widely reported in the press. This is the incidence of diphtheria cases in 2019 to 21. You see that Tamil Nadu has contributed to 24 cases in the year 2020 and 21. This is gross underreporting, which we must accept. The age distribution pattern of diphtheria cases in South India between 2019 and 2021 shows that the percentage of diphtheria cases in children less than 5 years, which is depicted in red, is showing an increasing trend. The first case VIGNETTE which I would like to share is a 4.5-year-old boy was referred for low-grade fever, cough and sore throat for 5 days. On day 1, taken to a private clinic, diagnosed as pharyngitis and prescribed oral antibiotics and antipyretics. On day 3, he had fever and sore throat, which resolved, but developed neck swelling, dyspnea and dysphagia, immunized with 3 primary and 1 booster dose of DPT. On examination, there was grayish-white membrane present over the tonsils and pharynx. There was inspiratory stridor, poor air entry, but no adventitious sounds was heard. Antitoxin was administered on admission and treated with crystalline penicillin. Child was intubated for worsening stridor and died 3 days later when an attempt for reintubation was attempted for obstruction. Whether early tracheostomy would have saved this child is $1 million question. Case 2, an 8-year-old male child was admitted with history of fever for 5 days. Child was fever-free for 2 days prior to admission. There was throat pain, difficulty in swallowing, and hoarseness of voice for 3 days. There was history of immunization with 4 doses of DPT. On examination, there was white membrane over both the tonsils and pharynx. Treated with third-generation cephalosporins and crystalline penicillin. The child developed hypotension few hours after admission. Inotropes were started promptly, subsequently developed ventricular arrhythmias, and in spite of defibrillation, child expired the same day. The third case was an 8-year-old male child who was admitted on with fever for 4 days, cough and cold for 4 days, breathing difficulty for 4 days, and swelling of the left side of the neck for 4 days. On examination, there was bilateral hypertrophied tonsils with grayish-white membrane over the left tonsil. Child was partially immunized, treated with third-generation cephalosporin, and since the child was toxic, in the second week we have added erythromycin. The ENT opinion was very dogmatic that it is only acute membranous tonsillitis. The Albert stain was negative. The child developed facial puffiness and bilateral pedal edema on week 3. The ultrasound abdomen showed type 2 RPD. After a few days, he developed tachycardia, tachypnea, and respiratory distress. The echo showed hypokinesia of the left ventricle. Ejection fraction was 30%. Week 4, when echo was repeated, there was dilated cardiomyopathy, which was treated with beta blockers and AC inhibitors. Week 6, the child developed dysphagia, drooling of saliva with nasal regurgitation and proximal weakness of all 4 limbs. Nerve conduction study was suggestive of AIDP. Child gradually regained motor function. Child was discharged after 8 weeks of hospitalization with complete neurological recovery after all these complications without antitoxin administration. What is evident from all these 3 case vignettes? A child presenting with sore throat, adherent tonsillopharyngeal pseudomembrane with low-grade fever may be misdiagnosed as acute membranous tonsillitis. A child who presents with congestive cardiac failure or arrhythmias or symmetrical polyneuropathy, if the pseudomembrane has not been picked up earlier by examination of the throat, would be wrongly labeled as viral myocarditis or Guillain-Barré syndrome. For clinical diagnosis, diphtheria can be labeled when there is an illness of upper respiratory tract characterized by the following: either laryngitis or pharyngitis or tonsillitis, an adherent membrane of tonsils, pharynx, and or nose. Thus, tongue depressor has become a rare commodity in our wards, and the present generation residents do not carry a torch. Unless you examine the throat, you are very likely to miss diphtheria at the early stages when it is eminently treatable. Membranous tonsillitis present acutely with more constitutional symptoms. The tachycardia is proportionate with high spiking temperature, and there is the membrane is usually bilateral. There may be whitish yellow, thin, limited to tonsil, and easily removable with enlarged jugular digastric node. On the contrary, diphtheria has an insidious onset of presentation. They may have disproportionate tachycardia due to myocarditis or dysfunction of the vasomotor center. They have low-grade fever. The membrane may be unilateral. It is gray, thick, and bleeds on removal. And there is a generalized cervical lymphadenopathy. These are the complications of diphtheria. They have bull neck, which is evident in this picture depicted. They have massive cervical lymphadenopathy with edematous swelling of the submandibular region. They have cardiac complications in 10 to 25%, which contribute to nearly 50% of the mortality in diphtheria in the form of myocarditis, arrhythmia, and cardiomyopathy. They have neurological complications between 3 to 7 weeks after onset of sore throat in the form of bulbar dysfunction, palatal, laryngeal, pharyngeal paralysis, facial and oculomotor cranial neuropathies, or ciliary paralysis or symmetrical polyneuropathy. They may also have acute renal failure. For diagnosis, 2 specimens of throat swab or nasopharyngeal swab or pieces of membrane need to be collected within the first 4 weeks and transported in Amis transport media, which is available in the DD office, at a temperature of 2 to 8 degrees centigrade. For laboratory confirmation, direct microscopy of the smear by Albert stain or for that matter gram staining is not advocated by the WHO. Culture of organism on special media containing tellurate can be undertaken, but for confirmation you require toxicity test, that is LX test, where there is a double diffusion of the antitoxin and toxin which forms a precipitate is a must, or a PCR to find out the regulatory genes which which produce the toxins is required. The general principles of treatment of diphtheria, you will have to collect the specimen prior to treatment. Early treatment reduces complication and mortality. You should not wait for laboratory results to start antitoxin, and isolation of the patient for 14 days and subsequently till they turn out to be culture negative twice is required. Antibiotics have no impact on already established toxin-induced lesion in diphtheria. They may at best eradicate the organism, thereby preventing transmission and also stop the toxin production. The drug of choice for diphtheria is either crystalline penicillin 1.5 lakh units per kg per day in 3 divided doses for 14 days, or the macrolide erythromycin 40 milligram per kg per day in 4 divided doses for 14 days. Antitoxin is the definitive treatment for diphtheria. It is hyperimmune antiserum produced in horse, and it needs to be administered either IM or IV. IV is preferred in severe cases. It reduces case fatality. The recommended doses are tonsillar diphtheria 10,000, pharyngeal or laryngeal diphtheria 40 to 60,000 units. For extensive disease like laryngeal or pharyngeal diphtheria lasting for more than 3 days, you require 1 lakh units to be administered. For all practical purpose, these children present after 3 days, so we invariably end up giving 1 lakh. The entire therapeutic dose must be diluted in normal saline and administered over 2 to 4 hours to prevent sensitization by administering repeated doses. Diphtheria will not produce sufficient antibodies and protect the individual for life. So they need to be vaccinated. Partially immunized child who is less than 1 year have to be administered the remaining doses of DPT. If the child is unimmunized less than 1 year, you'll have to start the schedule and complete all the vaccines as per the schedule. That is the 3 primary doses at 6, 10 and 14 weeks, and 2 boosters between 6 to 24 months and at 5 years. In children who are more than 1 year, you start with the DPT followed by the second and third doses of DPT at 1 month interval, with boosters after 6 months and at 5 years. The second childhood booster is not required if the last dose has been given beyond the age of 4 years. If you are giving the first booster beyond the 4 years, then probably the second booster is not required. If the child is more than 5 years, then probably you will have to administer 3 doses at 0, 1 and 6. Less than 7 years, it is DTWP or DTAP, and above 7 years, it is TDAP at 0 dose, and the first and 6 months, it is TD. Supportive care, in the second week, regular ECG monitoring must be done for conduction defects and arrhythmias, and you will have to have special attention to the airway. Judicious intubation to maintain continuous patency of the airway is a must. It is very dicey to recommend tracheostomy or mechanical removal of tracheobronchial membrane. On the right, you see the diphtheritic membrane. Actually, like when we try to re-intubate a child which we have intubated assuming it is tonsillitis, the whole membrane came out. This is how the membrane looks. This is for the first time I saw such a huge membrane. Contacts need to be observed for 7 days for diphtheritic symptoms. They'll have to be cultured, and they need to get chemoprophylaxis with erythromycin for 7 to 10 days or benzathine penicillin. 6 lakh per units less than 7 years, and 12 lakhs above 7 years. Do we need protection as healthcare professionals? Yes. If you're not immunized, kindly immunize yourself with Tdap and follow it up by TD every 10 years. The Advisory Committee on Immunization Practices US advises that Tdap can be given for instead of TD wherever possible, because the side effect profile is the same. But Indian Academy of Pediatrics Advisory Committee has not endorsed the same. Coming to the second part of my talk, which is pertussis. This is the incidence of pertussis case. Actually, there are no cases reported in 2020 and 21. This is gross underreporting, which is happening in our country, because it is a fastidious organism, and where the growth or confirmation is not possible in pertussis in our setup. Why there is a pertussis resurgence? Because of the waning immunity from vaccination, lesser duration of protection in fully vaccinated when compared with natural infection, lower vaccination coverage, antigenic shift because of the genomic changes in the pertussial antigens. There is increased recognition of pertussis, improved diagnostic testing and reporting. When there is poor immunization coverage, there is high incidence in the first years of age. There is frequent natural boosters because of pertussis. Hence, there is immunity in adolescents and adults, so the disease prevails in young children. In developed countries, what's happening? There is low incidence of pertussis because there is high coverage rate, high immunization coverage rate, so there is less frequent natural boosters, which can happen also in states like Tamil Nadu. There will be waning immunity in adolescents and adults, which will lead on to diseases more frequently in infants less than 6 months of age, because there is not much of cross protection from the mothers, and in adolescents and adults. Pertussis will present in adolescent and adults and in infants less than 6 months of age. Pertussis is a coughing illness lasting 2 weeks without an apparent cause, with one classical sign of pertussis, which is paroxysmal cough, or post-tussive emesis, or inspiratory woof, or apnea with or without cyanosis for infants. The DD for a pertussoid cough, or Bordetella parapertussis, Mycoplasma, Chlamydia, adenovirus, RSV, influenza, foreign body aspiration, endobronchial tuberculosis. The catarrhal stage is something like a common cold-like illness. Then the paroxysmal stage, you have bouts of machine gun-like numerous rapid cough in a single exhalation. The child's eyes will be bulging and watery, the chin and chest held forward, tongue protruding maximally, face purple until coughing ceases, woof at the end of the paroxysm. At times, there will be post-tussive emesis. The number and severity increases. In convalescent stage, episodes of cough are less frequent and severe. Paroxysm of woofing disappears. Volume. This is the classical pertussis with a woof. A 60-day-old infant presented with cough and cold 10 days, cessation of breathing with bluish discoloration of lips and extremities for 1 day, first dose of DPT not administered. Here you see this may be a pointer for diagnosing pertussis. The WBC count is high, and there is a relative lymphocytosis, 80%. And this is a confirmed case where PCR has been done and Bordetella pertussis proved, thanks to Dr. Palnichami, the assistant professor who gave me this video. Here, what do you see? After a cough, the child goes in for apnea. develops cyanosis. This is the classical presentation. In young infants, they don't have the characteristic oof. They'll have cyanosis and apnea. The investigation culture, sensitivity is very poor, like 15%, but the specificity is nearly 100%. It is inaccurate in late stages of disease. PCR, the sensitivity is 45% and the specificity is 85%. You get rapid results, most accurate in early stage of disease in the first 3 weeks. Serology is accurate in late stage of the disease, but the confounders may be maternal immunization as well as the primary and booster doses which the child gets. Testing methods not standardized in serological investigations. The complications of pertussis respiratory are apnea and pulmonary hypertension, and they may develop secondary complications like pneumonia, otitis media, sequelae of forceful cough, epistaxis, subconjunctival hemorrhage, intracranial bleeding, rectal prolapse, umbilical hernia, dehydration, and malnutrition. The neurological complications are seizures and encephalopathy. Here, the child is placed in respiratory isolation for 5 days. They should get macrolides for 5 days. Till such time, the child should be isolated. The treatment is macrolides, azithromycin or erythromycin. The alternates are clarithromycin and cotrimoxazole. All the contacts must be administered macrolides. Close contacts less than 7 years of age who have not received 4 doses of pertussis vaccine should have vaccination initiated or continued. More than 9 years or older, Tdap should be administered. Corticosteroids, beta-2 agonists, cough suppressants have limited role, but anecdotally, beta-2 agonists and corticosteroids are used in the treatment of pertussis. The strategies to prevent infant pertussis is single dose of Tdap during the 3rd trimester, 27 to 36 weeks of gestation preferred, regardless of the number of years from prior TD or Tdap vaccination. Tdap to be repeated in every pregnancy. This has been endorsed by the Indian Academy of Pediatrics Immunization Committee. Cocooning, that is like household members and close contacts are immunized at least 2 weeks prior to contact with a young infant to protect the unimmunized infant, and neonatal immunization like administration of acellular pertussis vaccine at birth is also tried but not come into vogue because they may impair the antibody response for the primary doses. So the carry-home message is pertussis to be suspected in children with predominant cough lasting for more than 14 days with classical oof, post-tussive emesis or paroxysm of cough, and in young infants presenting with cough and apnea. To consider diphtheria also as an etiology for children presenting with myocarditis and symmetrical polyneuropathy. Diphtheria antitoxin is the mainstay of therapy and may be administered on the basis of clinical diagnosis alone. Immunization with primary and booster doses at regular and recommended time will keep vaccine-preventable diseases at bay. And you should not miss opportunities for vaccination during physician-patient encounters. Thank you.
Thank you, sir, for a very excellent presentation. You have described in a nutshell, which we would have taken from books. Everything that was in our minds has been given in a very concise manner. I have a doubt whether the children who had fallen sick in the case of diphtheria and also